My topic is update on pharmacological advances in anti-lipid treatment. Cardiovascular disease are the leading cause of morbidity and mortality worldwide. According to WHO, it is the leading cause of death globally. 17.9 million deaths per year occur due to cardiovascular diseases. Risk factors of cardiovascular disease are hypertension, diabetes, smoking, dyslipidemia, lack of exercise, obesity, poor diet, and poor sleep. These have been discussed by Shehbaz Saab in the early hours of the day. Dyslipidemia increases there are 2 times greater chance of developing cardiovascular disease in patients with dyslipidemia. The global burden of dyslipidemia has increased over the past 30 years, with an elevated plasma LDL cholesterol being 8th most important risk factors for death in 2019. Dyslipidemias are either primary or familial or secondary. 2% of dyslipidemias are familial, which are caused either by genetic defect in a single gene or multiple genes. Secondary causes of dyslipidemias are metabolic, which include diabetes mellitus, lipodystrophy, glycogen storage disorders, chronic renal failure, glomerulonephritis, nephrotic syndrome. Among hepatic causes are cirrhosis, porphyrias, primary biliary cirrhosis, some hormonal causes like hypothyroidism, which is very common in our community. Lifestyle changes, physical inactivity leads to dyslipidemia, obesity, diet rich in fats, saturated fats, alcohol intake, and smoking. And there are some medications which also lead to dyslipidemia, like retinoic acid derivatives, glucocorticoids, exogenous estrogens, thiazide diuretics, immunosuppressive, and so many other drugs. The high-risk patient for atherosclerosis are persons with documented ASCVD, type 1 or type 2 diabetes mellitus, chronic kidney disease, depending on their G4 status. In apparently healthy people, we should use a risk score to estimate 10 years risk of cardiovascular disease. So according to European Society of Cardiology, there are very high risk, moderate risk, and low risk population. Among the high risk are people with markedly elevated single risk factors with total cholesterol of more than 310 or LDL level of more than 190, systolic blood pressure more than 180 by 110, familial hypercholesterolemia without other major risk factors, moderate CKD with the G4 of 30 to 59, and G4 less than 30 is a very high risk factor. A calculated score of more than 5 but less than 10. Moderate risk factors are young patients with type 1 diabetes mellitus of age less than 35 years, and type 2 diabetes with age less than 50 years, and diabetes duration of less than 10 years, without other risk factors, or a calculated score of more than 1 but less than 5. And low risk people are those with a risk of the score of 1 or less than 1. So treatment targets and goals for cardiovascular disease prevention, and we have to stop smoking. Diet should have healthy diet, low in saturated fats, with a focus on whole grain products, vegetable, fruits, and fish. Physical activity, at least 30 to 60 minutes regular walk per day. And I advise to my patient to do exercise to the extent that they either get tired or they have some symptoms, because exertion is different for different people. Body weight, one should keep BMI in the range of 20 to 25 kg per meter square, and waist circumference of less than 94 centimeter in men and less than 80 centimeter in women. And blood pressure should be less than 140 by 90. treatment targets and goals for cardiovascular disease prevention of LDL cholesterol in patients with very high risk in primary or secondary prevention. The therapeutic regime for LDL should be to reduce LDL to 50% of the baseline to a level less than 55 milligram per deciliter. If no current statin use, then they need high dose statins. If a patient is already on statin, then they should intensify the dose of statins or add other drugs. In high-risk patients, a therapeutic regime that achieves at least 50% reduction in LDL cholesterol from the baseline to a level of less than 70 milligram per deciliter is advisable. In patients with moderate risk, the goal is less than 100 milligram per deciliter, and in low risk, the goal is less than 116 milligram per deciliter. Non-HDL cholesterol goal is less than 85, 100, and 130 in very high and moderate risk people. There is no goal for triglycerides, but less than 150 is advisable. It indicates if a level of triglyceride is above 150, it indicates lower risk, and higher levels indicate a need to look for other risk factors. HbA1c should be kept less than 7%. This diagram shows metabolic pathways of lipoproteins. These are absorbed from the gut, metabolized, and the liver. Liver plays a very important role in cholesterol metabolism. They pick LDL and converts and to metabolize it. Cholesterol is also synthesized in the liver. Current lipid-lowering medications are statins, which include atorvastatin, fluvastatin, rosuvastatin, simvastatin, ATP citrate lyase inhibitors, bempedoic acid, PCSK9 inhibitors, which currently includes three drugs: evolocumab, arilikumab, and inclisiran. Cholesterol absorption inhibitors, ezetimibe, which is commonly used and is marketed frequently, bile acid absorption inhibitors, cholestyramine, cholestyramine, and there are fibrates, bezafibrate, fenofibrate, and gemfibrozil, and niacin and nicotinic acid, which is not commonly available now. Statin is the cornerstone of treatment of hyperlipidemia. They reduce biosynthesis of cholesterol in the liver by inhibiting the enzyme HMG-CoA reductase. This reduction in hepatic intracellular cholesterol promotes increased LDL receptor expression at the hepatocyte level, result in increased uptake of LDL from the blood, and decrease its plasma concentration. Statins are highly effective in reducing LDL cholesterol and the risk of cardiovascular disease. Role of statins both in primary and secondary prevention is well supported by robust clinical data. Patient intolerance with high dose statins, patient tolerates statin very well. Addition of ezetimibe complements the lipid rolling effects of statins. This chart shows the dose-related effect of statins in reducing LDL cholesterol. The most important is rosuvastatin. Rosuvastatin at 5 milligram reduces LDL cholesterol by 40%, and with 40 milligram reduces by 55%. And second is atorvastatin, which reduces LDL cholesterol by 47% when used by 51% when used in 80 milligram daily doses. Ezetimibe alone, it reduces the LDL cholesterol by 20%. Bile acid sequestrants, cholestyramine, cholestyramine, they reduces cholesterol by 15%. Effect of cholesterol on HDL, they increase HDL level by 1 to 10% depending on various statins. Statin usually reduce triglyceride by 10 to 20%. Rosuvastatin and atorvastatin are more effective in lowering triglycerides. The magnitude of lowering triglycerides with statins may be larger in patients with hypertriglyceridemia. Statins have pleiotropic effect. They diminish platelet adhesion. They reduce platelet aggregation. They have anti-inflammatory characteristics, improve vascular tone. They lead to reduction in oxidative stress, and vascular smooth muscle cells proliferation is reduced. This slide shows that statins lead to inhibition of membrane translocation of small proteins, which leads to endothelial nitric oxide synthase, which reduces subclinical ischemia and interstitial fibrosis. They decrease NADPH oxidase and decrease cardiac damage, decrease myocyte hypertrophy and myocyte apoptosis. These effects improve heart failure. There are some drugs which interact with statins and increase this. Two side effects of statins are myopathy and rhabdomyolysis, although these are very rare, but in combination with these drugs, because they inhibit CYP3A4, which also metabolize statins, they increase the side effects. Ezetimibe is the second most commonly used drug nowadays. Named PEC-C1 protein, a transporter located on the brush border of membrane of jejunal enterocytes. That is its target. It inhibits sterol transporter at brush border and consequently intestinal absorption of cholesterol. It decreases delivery of cholesterol to liver and reduced hepatic cholesterol stores. This picture shows a decrease in the absorption of cholesterol by ezetimibe, which leads to decreased cholesterol in liver, and in response there are increased expression of LDL receptors on hepatocytes, which clears LDL from the circulation. PCSK9 is a very important drug which reduces inhibitor of PCSK9 and reduces cholesterol to a greater extent. PCSK9 degrades LDL receptors. When the LDL is attached to LDL receptors at hepatocytes, these are internalized and these are either metabolized and the receptors are transported back to the hepatocyte cells, or they are degraded. So PCSK9 degrades the PCS receptors. PCSK9 inhibitors inhibit the PCSK, and it leads to increase in the hepatocyte receptors of LDL. There are monoclonal antibodies for PCSK9, evolocumab and alirocumab, and there is clinically synthesized small interfering RNA molecule that reduces production of PCSK9 and clarithromycin. PCSK9 inhibitor reduced LDL in the range of 40 to 72% from baseline, either in combination with statin or as immunotherapy. They reduce total cholesterol significantly. There is modest increase in HDL cholesterol and decrease in triglyceride. These are given by subcutaneous injection once or twice a month. Their safety and tolerability profile have so far been excellent. Alirocumab has a room stability of 24 hours at room temperature, then needs lab protection and refrigeration for storage. It is administered as 75 or 150 milligrams subcutaneously every 2 weeks. It is FDA approved for addition to a maximally tolerated statin dose for familial hypercholesterolemia or those clinically ASCVD with suboptimal LDL lowering. But the cost of this drug is $14,600 for 1 year of therapy. The Cartes trial showed efficacy of PCSK9 inhibitor and its safety. It also increases HDL level and APO2 level. The phenofibrates activate peroxisome proliferator activated receptor alpha, PPAR alpha, increase lipolysis and activated lipoprotein lipase and reducing apoproteins C3. PPAR alpha is a nuclear receptor and its activation alters lipid, glucose, amino, and amino acid homeostasis. Phenofibrate, it decreases triglyceride to a greater extent. They reduce inflammation. They reverse cholesterol transport. These use of phenofibrate along with statin increase the incidence of myopathies. Then is bempedoic acid, which acts by inhibiting adenosine triphosphate citrate lyase and consequently cholesterol biosynthesis. It increased expression of LDL.
Please wind up your presentation. Time is over.
Okay. And increasing LDL plasma clearance. It is a prodrug. It is used in patients who are intolerant to statins. Yes, it. Just this patient. I will show you one slide. Most of the people show good response to statins, but I have 2 patients with familial hypercholesterolemia who do not respond to a maximal dose of atorvastatin 80 milligram along with ezetimibe. So some people need PCSK9 inhibitors. And moderate intensity statins reduce LDL cholesterol by 30%, high intensity statins by 50%, high intensity statins plus ezetimibe by 65%. PCSK9 inhibitor alone reduce LDL by 60%, and in combination, all these reduces LDL cholesterol level by 85%. Thank you.